All right, welcome everyone, and thank you for joining us for another Aortic Nuts America monthly series. We have today presenting to us UCSF. We are happy to have them lead today's talk. As we're waiting for people to join, we also do have after the ASCO, we have a best of ASCO occurring 4 weeks after. That is in person. First best of ASCO occurring in person in Ethiopia. That is June 27th and 28th. Then we'll be moving on to have our basic scientists having something in July. Remind me, Bemura, what's the title of that? So I mhm. So that's going to be in July in Ghana. I believe everybody has that. And then of course this is our year in Tunisia. Everything ends in Tunisia. I look forward to meeting everybody in person in Tunisia. Hi, Katrin, how are you? All right, thank you everybody for joining. This month again, we have UCSF. I am pleased to actually introduce Dr. Gregory Broccoli. He is an assistant professor, also GI medical oncologist in the Division of Hematology Oncology at UCSF. He's leading this topic of this discussion today, and his research focuses on the etiology, early detection, and treatment of esophageal and squamous cell cancer in East Africa. So he has here with him his team from Africa, and he will be leading the show today. Thank you very much, Gregory, for joining us today. And I am moving everything over to you. Thank you.
Great, just checking that you can see my slides. Is it okay?
Yes, we can.
Terrific. Well, great. I'll be providing a brief introduction to the UCSF Tanzania Cancer Collaboration and a focus on the importance of context-specific evidence to improve cancer care and policy in Tanzania. So just as some brief background, the partnership between UCSF and Muhimbili University in Health and Allied Sciences dates back to 2005 that was oriented around an academic learning partnership. In 2017, UCSF partnered with institutions in Tanzania to establish the UCSF Tanzania Cancer Collaboration with a dedicated focus on cancer research and training. The founding leadership was Dr. Iliam Baga, as well as Dr. Catherine Van Loon. Collaborating institutions include MUHAS, Muhimbili National Hospital, and Ocean Road Cancer Institute, though as the program has grown, there are others. A core focus of the Tanzania UCSF Cancer Collaboration is the D43 funded Cancer Research Training Program. There are three pathways that are the focus of this program: a clinical research pathway, which is focused on clinician scholars, a cancer research pathway that's embedded into the Masters in Medicine program, which is analogous to a residency focused on cancer care or fellowship focused on cancer care. And then there's a doctoral level research pathway, which is a four-year program that includes coursework at UCSF, as well as a return to Tanzania to complete dissertation. There are also intensive skill workshops and ongoing mentorship that's collaborative between UCSF and MUHAS faculty. This has been led by Dr. Van Loon as well as Dr. Mbaga over the past 5 years. This program has been an immense success with a number of key accomplishments. There have been 48 scholars trained across the three pathways, including 3 PhD scholars. There's been development of core curriculum that's focused on cancer research, epidemiology, biostatistics, and research methods. All of the Masters in Medicine scholars have completed dissertation projects with shared mentorship, and there's a number of collaborative mentorship successes in terms of all scholars have had collaborative mentorship, and many have rated the mentorship extremely highly. We've been very proud of the success of obtaining extramural grants, including 14 that have been awarded to 9 scholars, including some of the highly competitive NCI, ASCO, ASH, and Fogarty GLOCAL funding mechanisms. We've had a pilot award programs with 36 applications submitted and 11 pilot awards funded. There have been 7 notable publications and multiple presentations at major international conferences. There is a current D43 that's under review for renewal of this program with direct funding to the Tanzania institutions. In just a moment, we'll hear from the PhD scholars that have been supported by this work, but before doing so, we'll provide some perspective on why the work that they're doing is so important. So as many folks know, cancer guidelines have emerged as a driving force for translating evidence into to policy and improved care. There's a number of different resource-adapted guidelines that have been developed, including resource-stratified guidelines, harmonized guidelines, which are stratified and then harmonized for a specific regional setting. And then there's also been a number of country-level guidelines that have been developed. Uh, these guidelines have served as a foundation for research with a number of publications that have come out looking at barriers and facilitators to guideline use, best practices for guideline implementation with work led by collaborators in Tanzania, as well as partnership from UCSF. And then increasingly, we're seeing evidence to support associations between guideline concordant care and improved outcomes. And this is work that's been led by the African Cancer Registry Network with impressive findings. So while resource-adapted guidelines are beginning to have an important impact on cancer care and policy in many low and middle-income countries, including Tanzania, we see critical opportunities for improvement and feel like this is an important part of the research that's being conducted by scholars. So first, there's a pressing need for more context-specific evidence. This is not a new idea. This is something that's been called out by leadership at the NCI for Center for Global Health, as well as those that even developed the NCCN harmonized guidelines. But it remains an important issue and one that deserves advocacy. There's also a need for a broader conception of evidence to address knowledge gaps. And this is an idea that we've been advocating for with the goal of developing better guidelines to translate into impact. We'll return to this point. So why is context-specific evidence so critical? Most resource-adapted guidelines are actually derived from guidelines developed for use in high-income countries. They take guidelines that have been previously developed and then make changes to adapt them for lower resource settings. As a result of this process, most evidence originates from high-income countries, and there's really limited context-specific evidence that's either featured in or shaping the guidelines. Our group has undertaken an effort to analyze the NCCN harmonized guidelines to characterize just how big of a problem this is, and this is work that has had that has benefited from critical roles of three D43 funded scholars that are featured here. This will be presented at ASCO in June as well. Excuse me, one of the oral presentations. So what are some of the limitations of evidence in its current form? Well, evidence from high-income countries may have limited generalizability to low resource settings. This is a concern that is familiar to many. This may be due to health system factors, and we've seen this in analyses of outcomes of treatment programs for Burkitt's lymphoma across sub-Saharan Africa with diverse outcomes across heterogeneous health systems, and some findings that have indicated that if you use some of the most intensive regimens, you have worse outcomes in this context. This may also be due to patient-level factors, and this is work that was led by Dr. Brooke Wilson that has showed that even amongst trials that have been carried out for FDA-approved therapies, we're finding substantial heterogeneity of treatment effect. We've also seen from research that's been put out by others that the lack of generalizability is likely a major barrier to guideline uptake in low and middle-income countries, and this is a critical point around usability. This is returns to the point around the broader conception of evidence. And historically speaking, we've seen most of these guidelines prioritize randomized control trials. This is featured at the top of the evidence pyramid in studies that have really designed to provide insight into the treatment effect. But as we begin to answer questions around the appropriateness for diverse resource settings and various contexts, there may be a role for more diverse sources of evidence, ones that give us insight into the implementation of treatments into settings with less resources. There's a few different pyramids that have been put out by a number of different groups that have tried to call into question the role of lower level of evidence that may play in exactly this policy issue of how do you translate, optimal treatment to settings that may not have optimal resources. So the final, points are we probably don't have a ton of time to dive into, but we also feel are critical to this idea of translating evidence into impact. We feel that there's a need for improved methods of developing guidelines to ensure that the innovative practice-changing research that's emerging from places like Tanzania is incorporated into the guidelines. And this is really shifting from adapting guidelines to placing more effort on identifying evidence sources to inform these guidelines. And there's also probably a role for developing tools to provide better insight into the generalizability of evidence that are featured into these guidelines so that we have a sense as we look into the guidelines, where is this evidence coming from? Is it high-income countries? is it similar settings or resources to what we're currently seeing? So some closing thoughts before we hear from the PhD scholars. Cancer care in many low and middle income countries is transforming rapidly with a growing clinician workforce and broader access to treatment. We also see cancer research accelerating with more and more context-specific evidence from resource-constrained settings. And I think perhaps nowhere is that more apparent than attending the aortic conferences when we see highly impactful research that's being carried out in a number of different countries. Generating this context-specific evidence represents a critical starting point and is absolutely essential for impact, but there's probably a need to harmonize this evidence generation with more inclusive approaches to evidence synthesis to ensure that guidelines and the care and policies they inform remain relevant, adoptable, and impactful for low and middle income countries. With that, I'm going to turn it over. Oh, sorry, a couple last comments. So the research that you'll hear in just a moment it has been funded by the Fogarty International Center from the National Institutes of Health. Just want to mention that this content is solely a responsibility of authors and doesn't represent the views of the NIH. And then, as I think everyone on this call probably knows, the work that is currently being carried out in the D43 program itself is one that is under immense threat based upon federal threats to funding and discontinuation of funding. And we're always looking for partners to help support the growth of this program and specifically supporting our scholars. So if folks are interested in partnering, we're always keen to build off of the work that's been done. So with that, I'm going to shift it over to Dr. Nasser, who's going to kick it off with a talk about CML.
Thank you very much, Dr. Bako, for the introduction. I am Dr. Helen. I'm a lecturer at the Muhimbili University of Health and Allied Sciences in Dar es Salaam, and also consultant hematologist at the National Referral Hospital, and I'm currently pursuing my PhD. So as a background, so the title of my study is Molecular Predictors of Treatment Responses and Treatment Outcomes among Patients with CML, Chronic Myeloid Leukemia in Tanzania. Next slide, please. So as a background, what is CML? CML, this is chronic blood cancer that has a specific genetic lesion. Understanding this genetic lesion has led to development of targeted therapies. The first one being imatinib, which was first introduced back in 2001. And later on, over the years, additional second generation, third generation TKIs have been developed. As a result, the overall treatment responses has resulted into overall survival globally. So we see patients currently of CML having similar survival rate to the general public. And therefore, the patients are no longer dying from the disease. As such, it has led to global shift of treatment goals to treatment discontinuation, as these patients, after attaining a specific molecular response, deep molecular response, it has been found that they can actually get off treatment and still maintain the molecular remission without relapse. So it is currently considered to be a treatable cancer. In Tanzania, we see 80 to 100 new cases of CML, and luckily we do have the targeted therapies, including imatinib, which have been available since 2009 under the Max Foundation. 2004, sorry, under the sponsorship of Max Foundation. Next slide, please. So what is the problem is this, if this leukemia is treatable and we do have the targeted therapy. So in our previous study, we found that compared to what has been reported elsewhere, we are actually seeing patients with very low molecular responses. So if I can get your attention to the first scatter plot that you are seeing, where you have the BCR-ABL ratio on the vertical axis and the horizontal axis that compares the time or duration the patients have been on treatment. The red line indicates, if you can click to the next for the animation, please. Yes, so the red line indicates that the patients, the ones who are above the red lines are the ones that do not have the appropriate molecular response. As you can see from the graph, it is majority of the patient. 2/3 of these patients did not have optimal response, and only very few were below this line. As a result, this translated onto the reduced overall survival. Next, please. As you can see, the red curve it showed the reduced overall survival of these patients that were above the red line on the scatter plot. Next slide, please. Following the results of this study, we came up with multiple hypotheses. The first is we did find that majority of our patients present with high disease burden compared to what has been reported in many clinical trials. So we have more than 60% of our patients as high-risk patients. And therefore, this led us to think that by the time our patients present, they already have molecular resistance to the medication that we are giving them. And if not a diagnosis, then the type of molecular resistance that they develop during treatment, which are they? And so that this will guide us into determining the second line of treatment for this patient. But also after our first study, we were able to make a case to get second generation TKI through Max Foundation. However, we do not know the response rate for this second generation TKI and toxicity. Next slide, please. So this led to the foundation of our current research, which we are currently trying to pursue by following two cohorts of patients. The first one, patients who are newly diagnosed, treated on imatinib, and we have 110 patients. And then the second cohort, we are following the patients who have been switched on second-line TKI. We are trying to better understand the molecular resistance and molecular pattern, but also their response rate and toxicity profile. This is a follow-up study of 2 years, and the main site that we are recruiting the patients is Ocean Road Cancer Institute, and the laboratory work that we are doing is all done in country. And in a nutshell, at diagnosis during enrollment, we are doing whole genome sequencing and also myeloid-associated mutations so that to better understand the mechanism of resistance. And we are following up patients by regularly monitoring their molecular response using PCR. But those patients who are not responding well, we are also doing sequencing to determine the type of mutations along the BCR-ABL kinase domain. That way, it will help us to determine which type of mutations they have and therefore the appropriate treatment. Next slide, please. So this is in a nutshell of the lab work that is currently ongoing. We do extract the DNA and RNA from whole blood samples for the patients recruited into the study, and we convert to cDNA. And we do library preparation and barcoding in-house, and we also do sequencing. So we use two platforms. For the whole genome sequencing, we are using Oxford Nanopore sequencer, and for the myeloid-associated mutation, we are using Illumina platform through the myeloid panel. Next slide, please. And this is a snapshot of some of the results that we have so far. And this is for myeloid leukemia mutations at diagnosis. So we were able to sequence 25 out of the intended 60 patients. And out of those, we found that majority of patients, 17, had mutations, and from those, 10 of them had more than one multiple mutations. And among these mutations, we have those that have been previously reported and the ones that have not been previously reported. Currently, what we're trying to do with the prospective follow-up of the patients, we are trying to compare their molecular response and their mutation status at diagnosis. Next slide, please. So what implication does this have? Basically, we are trying to develop and to generate evidence-based treatment guidelines. This is because we have found from our previous study, the population of patients that we have is different in terms of the disease burden that they present with, and their treatment responses and even toxicity profile is completely different from what is reported in clinical trial. So we speculated that there could be other factors, especially genetic factors that are influencing treatment responses, and therefore better understanding the mechanism of resistance will help us to choose the appropriate first-line TKI, and also when the patients failed the first-line treatment, which appropriate second-line treatment they'll be best benefit. And this will help us to have a better and rational use of limited available resources. As I've mentioned, these TKIs we're currently receiving them out of access program through Max Foundation. And we hope in the long run to develop African clinical score tools that will help us to identify high-risk patients who are likely to respond and who are less likely to respond. That way we'll be able to better decide in terms of the treatment choice. But lastly, and not the least, but of very important, research can be used as a milestone, a stepping stone to actually set capacity that has previously not existed. And we have seen this possible with our previous study where molecular monitoring was not done routinely, but after we had set the molecular and the logistic needed through the study, we were able to integrate that into clinical care. Mutation analysis is the standard of practice, but currently we do not have the platform for this. And we hope in the long run, after the study, we can integrate this skills and this platform into the routine care. And on the picture is demonstrates the capacity building that we are building in terms of human resource, but also in terms of the platform. Next slide, please. Thank you. I would like to acknowledge the mentorship I've received from the UCSF MUHAS Cancer Collaboration, but also mentorship from the University of Oxford, the department for all the support, and the teaching hospital, and all the funding mechanism to support my research. Thank you very much.
Next, I'd like to welcome Dr. Kamambo.
Thank you, Jeff. Hello, everyone. My name is Dr. Steria Kimambo. I'm a faculty at MUHAS and a consultant pathologist at Muhimbili National Hospital. And my project is focused on the determinant for implementing ultrasound-guided fine needle aspiration biopsy and rapid on-site evaluation practice for cytology sample in low resource settings. So why this project? So fine needle aspiration biopsy, it's a technique and it's often used as initial methods of tissue samplings in most of the low and middle income countries. Why? Because other methods such as tissue biopsy and core needle biopsy are prohibitively expensive and not feasible in some of anatomical locations. However, fine needle aspiration biopsy technique has some limitations in Tanzania. And some of these challenges include high rate of non-diagnostic FNA samples. And it can reach as far as 10%, and a false negative rate as high as 21%. Why do we have some of these high rates? It's because some of the personnel who are performing these techniques, they had limited training, but also most of our techniques, we are using what we call blinded FNAs. However, image-guided FNA has shown to increase the accuracy of FNA sample. What does the imaging do? It increases the visualization of a lump, and this will allow for a pathologist to put the needle on the right track for a better sample. But also there are some other techniques such as rapid on-site assessment for sample, and this is what we call ROSE. So what does the ROSE do is taking the sample and smear and put it under the microscope, and you visualize why the patient is in the clinic. So this gives you an opportunity to assess the adequacy of the sample before you discharge your patients, but also it can give you a preliminary diagnosis for you to triage the sample of these patients. So due to this, we have experienced repeated procedures, or at some point, some cases they've gone from fine needle aspiration to open biopsies, which is unnecessary at some benign conditions. But also it can delay diagnosis of patient, and it increases cost as well. Next slide, please. So we did a pilot study about 3 years ago, and we published this paper last year. So what we did, we were trying to see how rapid on-site can increase the sample adequacy, and we had 50 breast FNA sample, and what we found is that all cases that we sampled had adequate material for us to make a right diagnosis for patient to go to the next step. Next slide, please. So this has convinced me to work on these two interventions in pathology, which is use of ultrasound-guided FNA procedures for superficial lesions, but also to apply rapid on-site evaluation. So my research questions were three. One is, what are the barriers and facilitators for implementing ultrasound-guided FNA and rapid on-site evaluation? And this is qualitative study. And my second research questions were, what were the best strategies to implement ultrasound-guided FNA and rapid on-site evaluation? It's also a qualitative study. And finally, what are the implementation outcome? And this is going to be a mixed method where we are going to see, after we have having a best strategies, how are we going to improve the care? And this is the mixed method, as I said. Next slide, please. So some of the results that we have currently is from the qualitative study, where we have assessed the determinants, which are barriers and facilitators for implementing ultrasound-guided FNA and rapid on-site evaluation. So we interviewed different stakeholders. There were 23, and this include pathologists, surgeons, intervention radiologists, laboratory scientists, and some few administrators. So what we found that the major barrier was the inadequate space, but also lack of equipment, as we found that one of the most important equipment that we're going to need for this project is having an ultrasound in pathology lab, most especially in a fine needle aspiration clinic. But also increasing procedure time is going to be one of the biggest challenges, because in the previous it was one procedure, but now it will incorporate image, but also rapid on-site procedure, and this will increase the procedure time. But also what we also found is that there were no standardized training for fine needle aspiration biopsy in general, but also training that are more specific to image biopsy, image-guided biopsy, but also doing rapid assessment. So this is one of the major three barriers that we are going to encounter. But also what we found is that we have different collaboration, but also multi-institutional north to south partnership that we have, for example, with UCSF. And this may help us in this project in terms of, for example, funding and subspecialties, the association in partnership we have with different institutions across the country, but also out of the country. But also we have different curriculum that also try to train people to specialize more on cytology care. This is going to also facilitate this project. Next slide, please. And the important suggestion that we found, there are many suggestions, but I think the most important one is about the capacity. So we have to build the capacity and the quality management system so that to have available space and equipment that are needed for this project. But also training is a component which is very important, and it was suggested by most of the folks involved in the interview. Next slide, please. So what are the implications that we found in terms of the cancer care? So what we found is that there is high rate of non-diagnostic procedures when it comes to fine needle aspiration biopsies. And this has resulted into repeat procedures. And this is the major challenge. in the current practice. And this has upset many surgeons when it comes to patient care. But also there's a lack of capacity building and lack of standardized training. And this was reported in most of the folks involved in this interview. And so what we found is that the critical strategies to implement these two interventions is to have a multidisciplinary stakeholder involvement, which we are trying to build upon this project, but also to develop a rigorous training program and capacity to build the capacity and the quality system strengthening in the pathology lab. These are the most three key components of the strategies that we are going to impose and try to implement in our project for the second and the third objectives for this project. Next, please. So I would like to acknowledge my funders. This project has been funded by several grants, including ASCO, Pfizer, American Society of Cytopathologists, and UCSF, and from my mentorship team from MUHAS, MNH, and MSK for their time to guide me in this project. Next, please. Thank you. That's the end.
Thank you so much, Dr. Kumambo, for that terrific presentation. Next up, I'd like to invite Dr. Sarah Katika Nyagabona to discuss next.
Thank you, Jeff. So I am going to talk about my PhD program. I'm Dr. Sarah Katika Nyagabona, and my PhD is looking at barriers and facilitators to the treatment of breast cancer among women living with HIV in Tanzania. So this is evidence from a mixed method study that is part of my PhD. Next slide. So this topic was brought about by experience from the clinics, in essence that we are seeing women with breast cancer. So in Tanzania, breast cancer is the second leading malignancy among women. We are seeing around 4,502 women annually. And in terms of mortality, it is the fourth cause of cancer-related mortality in the country. But when we are in the clinics, what we had come to note was that we are seeing women coming with advanced stages. And this is true for both HIV positive and HIV negative. But for the HIV negative patients, they usually there is low screening coverage and there is low interaction with the clinical services. But for the HIV positive population, they usually have a minimum of 2 hospital visits with a general clinical examination. Hence, it raised the question as to why they would also come with late stages. But this is not a finding that is unique to Tanzania. Because reports from the African Breast Cancer Disparity in Outcome Study showed that in sub-Saharan Africa, HIV positive women also come in late stages, and also they have the worst treatment outcomes. And going back to the clinics in Tanzania, we also saw that there's usually delay in them starting or initiating care. This can be related to patients' whether complications from using their ART or complications that are related to other comorbidities they have. But also we noted stigma, which is a dual stigma for both the breast cancer and HIV was a common theme. And this was also reported in the African Breast Cancer Disparity Outcomes. Next slide, please. So my main question was to answer what is the burden and what are the facilitators and barriers to care for these women in Tanzania. So we use a pragmatic approach using a mixed method, utilizing both a quantitative prospective cohort and a qualitative arm. In the quantitative prospective cohort, we involved a total of 425 women. These were women receiving care at KSMC, Muhimbili National Hospital, and Ocean Road Cancer Institute. These are 3 institutes that cover more than 80% of patients with cancer providing care within the country. And out of these women, we saw that 47 of them were HIV positive, which we got 11% incidence in them. And we monitored their laboratory findings, but also we monitored their treatment timelines and also access to insurance that determines the interaction with the healthcare system. In the qualitative aspect, we wanted to answer what are the lived experiences and factors that drive this disparity that we are seeing. And we had a total of 21 interviews. These were conducted at the Muhimbili National Hospital and Ocean Road Cancer Institute. The participants were women living with both HIV and breast cancer, and healthcare providers ranging from nurses, pharmacists, doctors, and counselors looking at how they interact and what are the drivers that they see from their lived experiences. Next slide. So looking at our prospective cohort, what we found is late disease presentation, which is stage 3 and 4, is still a common finding. It is common both for the HIV positive and HIV negative cohort, but with a significant p-value indicating that the women with HIV, though they interact more with the healthcare services, they too do come with late stage. Insurance coverage was relatively high in our population, but this might be explained by the fact that we use the tertiary centers. Hence, most of the patients that we see were the ones that were able to afford care, and this affordability of care is usually driven by insurance coverage. So what else we noted is in terms of laboratory, creatinine levels were higher in women with HIV. That might be explained by the long-term use of ART, because the women in the cohort, most of them were using ART for more than 5 years before their cancer diagnosis. In terms of neutropenia, this was also significantly ranged in the HIV positive population. And in terms of testing, immunohistochemistry coverage was low. And this is because this is covered out of pocket, not covered by insurance. So most were not able to do the necessary testing that is needed. And this was significant in both HIV positive and negative group. Obesity was also common among both groups. And most of the patients had mild to moderate anemia. This was common in both HIV positive and negative, with very low coverage of normal hemoglobin in the group, which is less than 50%. Next slide. So in terms of what drives the late presentations, stigma and non-disclosure was one of the problems, where we have patients being afraid to get a second diagnosis that is stressful. But also once they come to the oncology clinic, most of them try to hide their HIV status so that they can avoid anticipated stigma from healthcare providers as they get their cancer care. But also there was logistic constraints. Most of the patients usually have their HIV clinics in areas that are far from where they live. You might have a person living in Dar es Salaam, which is the coastal, but they do get their CTC clinic up country, which is far away. So once you incorporate the oncology clinic, which is within where they live, they usually are not eager to shift that clinic to the same place because of the disclosure, of course. And this now poses a logistic constraint, in essence, that they have these clinics that are far apart, and there is now a financial or logistic challenge in transporting them from one clinic to the next. But also the fragmented care system in the country facilitates and drives these late presentations, but also the psychological burden A lot of patients said handling both diseases is something that is rather crippling. Having to deal with HIV is one thing, but also getting a cancer diagnosis, sometimes they feel as if they want to give up and it's too much to bear. Spirituality and beliefs, it acted like a double-edged sword, where there were some who used faith as a coping mechanism to get care and find solace and acceptance, while others used it as an alternative to getting cure. And this leads to a lot of treatment delays. And this was noted. But in terms of facilitators, trust in healthcare providers, having a care that integrates and sees the patient holistically, having support in terms of somebody to talk to and somebody they can open up about. And as form of mental support, it's something that was echoed among all participants, but also education and empowerment, because they come from a community that has stigma related to both breast cancer and HIV. So even when you talk to them and try to empower them, you also have to go back to the community so that they can be accepted once treatment is completed and they can continue with life after cancer. Next slide. So what is the implication for care in Tanzania? So since the inception of our study, which was back in 2023, we noted that a patient needed support to navigate the fragmented care in order to promote early diagnosis and also adherence to both cancer and HIV, but also other comorbidities they might have. So this led to the inception of the Patient Navigation Program. This is an ASCO Sub-Saharan Africa Pfizer-funded program that is launched at the Muhimbili National Hospital. And another intervention was HATUA, stigma reduction intervention. This is looking at dual stigma, combating dual stigma for both HIV and cancer among women that are affected. This one is still awaiting funding, but what we noted is using tools for stigma reduction, especially anticipated and internalized stigma, because that is the one that still has the highest. It's around 18%, and for the past more than 5 years has not been going down compared to the other stigma that exists in the society concerning HIV. But also in terms of advocacy for service integration, looking at community partners and also speaking up in outreaches, trying to raise awareness that patient can look at their CTC or care treatment centers as a point of care interaction, that once they come to their doctors, they get a physical examination. It is an opportunity for them to voice out any other health issues and not wait until when the disease is at late stage to come back to the hospital. So to echo what Jeff and my previous speakers have said, this has really showed how context-specific evidence can be used to drive and integrate care models, and also to the importance of psychological support and how this can improve clinical outcomes for patients, vulnerable population, which in this case is the women with both HIV and breast cancer. So next slide. I would say asante sana, which is thank you very much in Kiswahili. And I'd like to acknowledge my funders. My PhD was funded by NIH D43 grant, ASCO and BCRF. My mentors, Professor Kasirin Mbaga and Professor Elia Mbaga, and all my other mentors that have supported me, the collaborators, and of course the participants, the brave women, healthcare providers that were willing to talk to me. They were willing to be members of this, participate in this study. Thank you very much.
Thank you to the USCSF team. This is very powerful, and we already have questions by the already posted. All right. So my question is, so I'm reading off the chat now. My question is directed to Dr. Hallam and the findings on the burden and mutations among our patients with CML. I'm curious to know, are there any associated factors that could predict the nature and mutation of a given patient? For example, the patient's characteristics or other routine labs that we do say, CBC, just in case there is a possible sustainable way for channeling patients to different TKI generations at the clinic, since PCR is not yet readily affordable. So that is Dr. Hallam's question.
Thank you very much. I think it's an excellent question, and that is actually what we are trying to answer from this research, to look above, beyond the mutation. Is there any way where we can predict, based on the clinical characteristic and routine blood test, the patients that have mutation and therefore are less likely to respond? As with regards to the PCR and the response, this we had established from our previous study. We found that patients who are actually presenting with high disease burden, as reflected by high white cell count more than 200, severe anemia that requires transfusion, and massive splenomegaly more than 20 centimeter, and another paper also done in Tanzania looked at hepatomegaly, liver enlargement. These also were indicators of the factors that contributed to poor treatment response, molecular response. As for the mutations, the one that are going to determine, that is what is we are currently trying to answer in the current research. Thank you.
Thank you. Then the next question was, I mean, if you have any question, please, you can feel free to raise your hand so we don't have to post everything in the chat. Next question, a good presentation. Question is to Dr. Sarah. How do you manage to prevent reputations of patients between MNH and ORCI, because some of patients at ORCI are referred from MNH?
Thank you for the question. Yeah, it is true that Muhimbili National Hospital is diagnosed the largest percentage of the patients, and not all of them are usually treated there. But all our patients had consented, and they were given study IDs, and their names were put in the same database. So once a patient is in the system, whether they are moving across centers, because some of them would move to get their chemotherapy at another institution, whether it will be at Ocean Road or if they are going to KSMC. So we keep track of the patients, and also we do phone call follow-ups. And once they present to the new center, they meet the team there. And if they're already recruited, then we just keep on monitoring their laboratory investigation. That is how we were able to avoid repetition.
I'm just curious, just as a follow-up to that, what is your follow-up rate? Do you have patients lost to follow-up? I mean, how many patients actually stay on your studies?
Okay. So in terms of continuing communication with the research team, we have a very high follow-up to that. But in terms of follow-up to treatment, that is where we are having challenges, because we can have patients that refuse surgery, or we can have patients that receive radiation. And so we are, as a team, we decided we'll follow them up regardless of their treatment options, or if they opt out of treatment due to personal or financial constraints.
Okay. Another follow-up question, I'm sorry. I mean, and this because I'm part of a trial ongoing in Nigeria, and I also see a problem with follow-up. And we know that patients, when getting treatment, especially chemotherapy and what have you, they get quickly lost to follow-up, and it could be due to the cost, financial toxicity, or just toxicity of the drugs itself. But now, when patients are now on trials whereby they are offered the treatment is probably free, we also see patients that are lost to follow-up, you know, and I begin to wonder that it has to be beyond just the treatment itself. Maybe there's something cultural that we are not paying attention to, especially in the clinical trial space, right? So it's not enough for us to be able to start thinking about clinical trials in those parts of the world, in Africa, but we have to start looking at the cultural context of it. So that leads me to your question now. You said that when a patient is getting treatment or surgery, then they get lost to follow-up. Do you think it's more something cultural that is going on? Or what would you explain the loss of follow-up in this patient who pretty much there's no financial toxicity, and the care of patients that are on trials, are kind of a little bit much more, because they have navigators, they have a lot of things, so it's quicker and it's a little bit different from the standard of care, but yet there's still lots of follow-up. So I just wonder, do you have any insight on why that is?
Okay, thank you. Yes, what you're saying is absolutely true. You have a patient whose treatment is covered, but they will still refuse. We have a high rate of that in terms of surgery, where some patients refuse to have mastectomy done. Sometimes it depends on the family or their social, how do I say this? It's like the support system they have. We have some patients that say, if I lose my breast, I don't think I'll be a woman enough, so I will not do it. As long as you give me this chemotherapy, I don't have a wound, I am okay. I am going to not have this surgery until I have it. So you have this patient coming back 2 years later with a laceration, and then you have to find, and now you are aiming for palliative treatment, well, before it was curative treatment. So these are women that we are seeing a lot of. What we decided to do as a team is to still keep in touch with them, because we still don't have a solution for that, but we still keep in touch with them, trying to ask how they're doing, trying to ask them to come back to the clinic. You don't have to have the mastectomy, but come back to the clinic so that we can monitor your progress. Not all of them come back, some do, but in terms of keeping contact telephone-wise, they still are in touch with the team. That's what I meant, that they are still keeping in touch with us, but they are refusing to engage in treatment. And most of the fear or refusal we're seeing is in mastectomy and in radiation. And sometimes you sit with a patient using navigators and using counselors trying to get them to get the treatment, but it goes back to the community, because they go back home, there are all these other stories they're hearing, and when they come back, the answer is no. They told me I can't do this. If you cut it, it will come back. The only solution is to not have surgery. Or if you do the radiation, it will only make it worse. So we came to realize that even giving them pamphlet about chemotherapy or radiation in itself is not enough, because this information, once they go back and they're other people who are still not educated, they misinterpret it, and they somehow still propagate the myth about treatment of cancer. So that's why I say there is a big part in terms of education and awareness. And what we're trying to do now is get a pool of survivors that they can speak about their experiences, because we are seeing talking as healthcare providers in itself is not having such a high impact, because we are speaking to them, telling them this treatment is helpful, telling them that this treatment, there are people who get treated and they survive, but unfortunately, the voices of the healthcare providers itself is not enough. So right now we are aiming at building a pool of survivors that they can speak their lived experiences, having a community or peer groups that can be able to support these women who are still not sure or not ready to receive treatment. I'm not sure if that was helpful, Abiola.
Oh yeah, it was very helpful. So yeah, pretty much there's no question. So I think at this point we have to start thinking about, looking good, right? The HIV counterpart. I remember in the 90s, HIV was a death sentence. Now I was on Instagram one day and I saw someone wrote, and they said, well, HIV, you just get a drug or two and you're fine. Cancer is a problem. And I'm like, oh, you can't say that, but it's true. So probably at this point, we start thinking of adding a plastic surgeon to the mix, right? And probably offering lobectomy, and probably even if you must do mastectomy, then you want to give them new boobs and kind of probably throw in a tummy tuck with it, or a BBL, I don't know. So I think if we're able to do that, and then we're able to kind of rewrite the script, because at the end of the day, most of these women, it's more about the body, the way they look, and pretty much that's it. So, Dr. George, this was very lovely. Dr. Catherine, this was very lovely. And UCSF team, this was lovely. And I think this discussion is very timely. I will keep on talking unless somebody has a question. Okay. So we have Best of ASCO, where we're going to be talking about Africans' access to innovative therapies, technologies, and resources. And it brings me to probably a question, or maybe food for thought, right? We talk about resource adapted and stratified guidelines, where when we look at all that and you compare it to the standard of care here, there's actually a gap, right? And then there's always this talk about the treatments that we have right now in low middle income countries. Most of the trials were not done. We're just taking something from high income country to low and middle income country and just chucking it in there without even testing to see if this is true. And now, if you're talking about best of ASCO in Ethiopia, it brings us back to the same thing, whereby we are talking about innovative therapies, we are talking about targeted therapies, but the trials that got this approved had very minimal minority patients, even in the US, and it got approved. Now we're talking about access to this. So I don't know what the answer is, right? Are we now saying that we want to go back and redo all these trials before we can accept and think that it's relevant in Africa, or do we just get with the program and move this forward? I mean, it's not a question; it's just a food for thought. Because that is what you're leaving me with now. I'm thinking about it. That how am I going to answer that question? Because I'm sure a lot of people are going to ask me that question. And I think I'll ask you that question to give me the answer in camera, because I really don't know what the answer is. Because are we going to start repeating all this trial for all these drugs? Or are we going to start saying that we need to get on trial? I don't know this.
I may suggest that the answer is the work that's being done that was presented here, which is generating context-specific evidence that isn't necessarily trials, but still highly informative and provides opportunities for inquiry that can help us understand what trials are necessary. I think all of the work that's been presented is on par with evidence, that's been produced in other settings that we're using to develop the guidelines. And I think that's a key point that I think is worth underscoring.
Absolutely.
Can I add on that? I don't think we are in a position where we can redo all the trials that have been done. I would also like to echo what Jeff was saying, the work done by Ahlam and Asteria in pathology, in terms if we can understand the molecular basis of the tissues and the tumors within the continent, it might be one step to help us see if these medication can work. Because I believe the genetic drivers usually would determine the responses. So if we can start mapping our genetics, our tumors, that could be a way for us to catch on the current immunotherapies, because there's a lot of talk on targeted therapies, but putting it in our population, we need first to get that genetic picture. I'm not sure if, of course, there are so many ways we can look at this, and phase 3 trials looking at responses and any resistance that exists. And I do say this is one of the great work Dr. Ahlam is doing, trying to look at how these drugs in our setting and what are the resistance we have, and are they useful as first line or second line in our population?
I think your team should actually be interested in joining the Best of ASCO, the African access to innovative technologies and therapies and resources. And I think that your voices has to be heard, right? Because it's going to be, I mean, it's the first of its kind. And we are having partners from industry, from policymakers, WHO, African CDC, and trying to talk about African access. So, and I think this conversation and presentation is timely, and I hope you'll be part of the team, and we hope to see you in Ethiopia. So again, this meeting is hybrid. I would love you to join in person, but if you're going to be joining online, that would be great too. So now we have come to the top of the hour. Stephen Ogiri said we can carry out effective trials, and Catherine is proud of our team. All right, so thank you, everyone. So top of the hour, thank you, everybody, for joining, and we'll see you not in the next talk is going to be in July. Thank you again, and have a lovely afternoon and evening for those people in Africa. Bye-bye.